So good evening, or should I say perhaps good afternoon, everybody, because the sun is still shining at the moment. And you're very welcome to tonight's COVID-19 question time webinar, all about safety at work, vaccines and treatments. Well, we've got some excellent speakers with us tonight to answer some of your questions. And I think it may be a good time just to start to do some of the introductory pieces while more and more of you I can see are joining the webinar tonight. So this is the COVID-19 question time webinar. This is, I think it's the 10th one we've run during the pandemic, and you're all very welcome, and thank you for joining us, and thank you for the questions that you have asked, which we will be asking, well, I'll be asking via our speakers tonight. So I wonder if I could ask Kelly, my colleague Kelly, just to move on to the first slide, and we'll explain how this is going to go this evening. We only have probably 4 or 5 slides in total, so if you're watching or listening to this on your phone, please don't worry, because you won't be missing out. It's just more a couple of prompts to us as we make our way through this 90-minute session this evening. If you are using Twitter, then do please let people know you're on the webinar using the hashtag COVID question time. At previous webinars, we've run a formal question and answer session at the same time as answering your questions live, but we had a bit of feedback that was sort of quite distracting for people. So this time around, we're not going to have a doctor answering the Q&A. If we see a question come up very frequently, we'll try to answer that as we go through, but we're not going to run it in the same way this time, because your feedback told us that was a bit distracting, and we're going to focus on the questions that you have submitted to us, of which I have quite a few pages of anyway. And I'm sure you'll let us know if that works better for you, or you'd like it to go back to the other way if you've been a regular attendee at these webinars. If you have any technical issues, please put them onto the chat box, which if you look at on my screen, it's the bottom of my screen, and put that in there. Of course, if you just want to say hi to each other or us on the webinar, that would be great. And someone's just told me the sound has dropped, so I'm going to turn myself up in case that's me, and I expect somebody will let me know if that's a problem. And also like to say that for any personal medical questions, please talk to your own kidney team. The webinar is going to be recorded, and we'll make it available on YouTube with subtitles, and we'll also be publishing a summary report on our Kidney Care UK website. So without further ado, if I could ask you to go to the next slide, please, Kelly, and let's introduce our fantastic speakers that we've got on this evening. So I wonder if our speakers, Rachel, Amy, Jonathan and Michelle, could just put their screens on, please, and we can introduce you all. And Jonathan as well will be great. That's okay. So the people we have on speaking to us tonight, we've got Dr. Rachel Middleton, who I'm sure some of you will know. I'm not going to read out everybody's qualifications because that would take too long, but she is a kidney doctor at Salford Royal NHS Foundation Trust with a wide interest in all sorts of different things. Secondly, we have Amy Gordon, who's an employment specialist, who's kindly going to respond to some of your questions about safety at work, and that is one of her specialties. We've then got Dr. Jonathan Leach, who's the NHS England Medical Director for Covid Vaccination. I don't know, Jonathan, I can't see you on the screen, so I don't know if you're able to come on and just wave, let me know you're there. And we've got Dr. Michelle Willicombe, who some of you have met before, again, kidney doctor this time from Imperial, and she has a specialty in sort of research and antibodies and all those kind of things as well. So she'll be asking some questions about some of that later on. And then myself, so I'm the policy director for Kidney Care UK, pleased to host this meeting tonight. I'm also a kidney patient, and my transplant is 15.5 years old at the moment. And then, hello, Jonathan, I can see you on the screen. That's great. Thanks very much for joining us tonight. And behind the scenes, I've got lots of colleagues from Kidney Care UK helping to make the slides work and making everything else work. So thank you very much to them as well. So if we could just go on to the next slide, please. And I'd just like to explain what the agenda is for us tonight. So we're going to be talking about what the current picture is with COVID, because you've asked us about that. And then we're going to be talking about how keeping safe nowadays, what's going on, Omicron, lots of other things there. Then we've got Jonathan, who's going to help to respond to some of your questions about vaccinations. That's Dr. Jonathan Leach. And we've got Amy Gordon, who'll be talking about some of the safety at work things we referred to. And we've got Dr. Michelle Willicombe, who'll be talking about COVID treatments and research, and also preventative treatments. And then Dr. Rachel Middleton and myself will be discussing some things about travelling as well, because you've asked for a few questions on that. So I hope that works for all of you. I'm sure you'll let us know on the chat if that's not right. And if we could just move on to the next slide, please. And we're going to be talking about the current picture with COVID-19 and how to keep safe. So if we could go off the slides, please, and focus on Rachel and myself. And if our other colleagues could switch their screens off just for the time being. And I don't think you need to spotlight me. I think you need to spotlight Dr. Middleton, please. If that's okay. Thank you. Thanks so much. It's always very alarming seeing your own face on the screen. Thanks very much then. And thank you for joining us tonight, Dr. Middleton. Right, well, Rachel, for the purpose of this, please, if that's okay.
Absolutely.
I wonder if we could start then with a current picture. Perhaps you could just kind of summarise for us very briefly what the current picture is with COVID, including what we know now about the risk of illness, and just setting the scenes about what we know about the current variants and the risk to people with kidney disease, people on dialysis and people with transplants. Is it getting any better?
Hopefully I can present a little bit more of an optimistic picture, Fiona. Thank you for the invitation today. So in terms of where we are currently with COVID-19 over 2 years on, it's actually a little bit more difficult now to get an accurate understanding of the current COVID-19 situation in the UK. And that's since the guidance changed across the 4 nations. So with the general public not having free access to lateral flow tests and PCR tests that we did have previously. And so to get an understanding, we need to look at the Office of National Statistics survey, which is undertaking a weekly survey of random PCR tests to get an understanding of the percentage of people in the UK currently positive for COVID-19. And we can also look at the Zoe research survey, which collects data on self-reported COVID symptoms to get information on the current situation. We can also look at hospital admissions and deaths. So of course, there is a lag between hospitalisation and deaths from the onset of a surge in cases. So if we had a surge in cases now, it would be 2 to 3 weeks before we would really be seeing that picture. So the good news is the Office of National Statistics data show that cases are falling across all the 4 nations of the UK, but numbers are still high. Around 2 to 3% of the population are currently infected with COVID-19. So about 1 in 40, 1 in 45 people currently affected with COVID. And so it's similar levels to early in December. And actually, if you look at the different age groups, the current infection is highest in those in the over 50 age group. Hospital admissions and deaths are also falling. I think there's around 6,000 to 7,000 people currently in hospital in England. However, I think over half of these COVID-19 is not the cause of the presentation to hospital, but either an incidental finding or, unfortunately, an infection during their hospital stay. And deaths are currently around 100 per day, so less than they were, but still a significant number of deaths there. And the ONS has actually produced interesting data looking at the proportion of disabled people that make up the deaths from COVID. And whereas in the UK, about 17% of the population will be classed as disabled, deaths are overrepresented in this population, with 60% in people who will be classed as disabled. So I think most experts would agree that thinking about the future of the pandemic, we should be expecting further waves. The current wave that we're in is due to Omicron BA2, and that's caused the majority of the cases in the last couple of months. And it was BA1 during Christmas and New Year that caused a huge surge in cases. But we know there's other Omicron variants on the horizon, BA4 and 5, which appear to be behaving similarly to the other Omicron variants, so highly infectious, but not causing the severe disease that we saw with variants prior to Omicron, such as the Delta variant. Currently, we've just got a few cases in the UK, and we don't have detailed information on whether people who've had Omicron earlier this year will be protected from these newer Omicron variants, and how effective vaccination is going to be at providing protection. And it's likely that these variants will increase over the next few months.
So just to summarise then, so where we are now is a lot better than certainly than we've seen before. Numbers are definitely down, but clearly the future with a pandemic is not possible to predict. And these new variants are coming in, and we're watching closely what is going on with them and how it will affect our population. Is that kind of a reasonable summary of that? There's sort of reasons to be cautious but cheerful, but slightly more cheerful.
Yeah, absolutely. Cautiously optimistic.
Right. Well, that's probably a good way for us to start. Could I just ask you? Someone has said, will it ever become endemic? And if you could just explain what endemic means, because one of the other feedbacks we've had from people is that we all tend to use terms that not everybody understands. So, but even the media uses this term endemic, and so if you could explain that, and any thoughts you have about where it may become that way and less or not at all life-threatening would be great.
Yeah. Okay, so currently COVID-19 is classed as a pandemic, and it would be classed as endemic when it would be thought to be not causing a significant disruption to daily lives, and that cases were at a predictable level, perhaps with some seasonal variation. So this would rely, I believe, on there not being significant variance over the next few months and years, and for the vaccine uptake to remain high for us to get to a situation that we could say it would be endemic. So we're not there yet. I think the Chief Medical Officer thinks that we'll be reaching a state where there'll be seasonal surges similar to flu, but with the occasional interspersed new variant causing small surges in cases over the next few years. And the World Health Organization also expects that to be the picture, but obviously advises caution with this disease where mutations can occur quickly and unpredictably, that things could change quite quickly. But at the same time, yes, agree that cautious optimism that we will be reaching that level, but not yet.
Okay, all right, thank you. And a good question that's come through, which is about, are those of us who've never had COVID lucky or immune, or have we perhaps had it asymptomatically and we don't know?
That's a really good question, and I hope long may they continue to not have COVID. I suspect it is likely people have had COVID asymptomatically. If we think back, as I just said, there are a high number who are being picked up as having COVID when they're being admitted to hospital without symptoms of COVID. And I'm certainly aware of people with transplants under my care admitted with other unrelated illnesses who've tested positive on admission. Again, we also screen our hemodialysis population weekly, and then we contact those patients to discuss symptoms, to access antivirals, etc. And the majority of people I speak to have had no symptoms. So I think there's a good chance that people have had the infection asymptomatically. Having said that, people have been very careful about shielding and low risk activities, as well as effective vaccination. So these will all play a part in some people avoiding infection. I don't think there's good evidence at this stage that there's a core population who have super immunity to COVID. And so I wouldn't be letting my guard down and thinking that I was one of those fortunate ones.
Okay, lovely. Well, thank you for that. I thought, again, I agree that's quite a nice question, isn't it? So I wonder if we could then move on a little bit and just talk about what we should still be doing at the moment to keep ourselves safe. So should we still be shielding? Should we still be wearing a mask? Should we be meeting up with other people? Should we be wiping down our shopping? What's the guidance on that?
Okay, so I think when we're thinking about what people with kidney disease should be doing to keep themselves safe, the first thing I always say is that it should be stressed that there's no hard and fast rules, that this is guidance, and I talk about lower risk versus higher risk activities. And I'd encourage everyone to think about what is right for them, what level of risk they would be comfortable with, and consider the other risks to them by the decisions that they make. So the risk to their mental health if living in social isolation, for example, the risk to their physical health if they're not getting regular exercise. So I think it's important that people do what feels right for themselves. As we mentioned, Omicron variant has behaved much better than previous variants in terms of not causing as severe disease particularly in people who have been fully vaccinated. So on that basis, I think it's a good time to think about testing yourself and going out a little if you have been shielding up to now. It's probably not going to feel normal, it will feel quite strange, but I would have some optimism to have a cautious reintroduction of some of your favoured activities that you would have done pre-COVID. In terms of wearing a mask, I think absolutely yes. COVID remains an airborne virus, and a fluid repellent surgical mask at least I think is an important protection. And I can't think of any argument for not wearing a mask. As well as COVID-19, masks help protect from other respiratory illnesses, and more recently there have been surges in influenza A and respiratory syncytial virus. These have both been high in the community, so masks have an added benefit there.
Sorry, can I interrupt? What was that other thing you just said? You said flu and something else.
RSV, it's abbreviated to respiratory syncytial virus. So it's one of the sort of common upper respiratory tract infections that people can get that can lead to other ill health and admissions to hospital.
Okay, thank you. So definitely masks, and I'm sure. What about meeting up with other people outside? The weather's smiling.
So yeah, coming into the spring, summer months, it's a good time to meet people outside, which is a safe thing to do. We can head to those Jubilee Street parties in the next few weeks and feel reasonably secure being outside. If you can't meet people outside but need to be inside, then making some simple measures to improve the safety. So a well ventilated room, windows or doors open for short periods of time, and perhaps just with a few people, will be the safest as you build up your confidence. Hopefully your friends you're meeting up with are fully vaccinated. It would be nice if contacts of the clinically extremely vulnerable had access to lateral flow testing freely available, but unfortunately that's not the case. But certainly avoiding people who have had a temperature or COVID-like symptoms in the few days prior to meeting up would be recommended.
Okay,
you mentioned about wiping down shopping. I don't think there's a need to do this. As I said, COVID's an airborne virus. The microdroplets are more likely in the air rather than on landing on your shopping. So I wouldn't be inclined to continue to do this.
Okay, well, that's helpful to know that we don't need to keep wiping down our shopping. In fact, I have stopped, but I know that some people are continuing to do that. So Right, okay. Now, a couple of very specific things, and then we'll move on to Jonathan, because you've talked about vaccination a couple of times, and we'll also be talking about the other treatments and things as we go through the webinar tonight that Rachel, Dr. Middleton has referred to. So just a couple of things. How about being in a church service where not everybody is masked? I mean, churches are quite large, but on the other hand, well, many of them are, but on the other hand, whether they have the windows and doors open, I don't know. So do you have any thoughts on that?
I think this then does come down to personal choice and risks that you're willing to accept, because yes, in a building that's with a large congregation, there is a risk there, particularly if masks are not being worn. Again, if it's something you choose to do and it's important to you, then going to a church service that's perhaps one of the quieter ones, maybe sitting in a less well occupied area towards the side or near a window or door, as well as obviously wearing a mask yourself and taking some hand gel with you, will be the measures I would undertake to help reduce the risk. So it's possible, it's not without risk, but I think with some careful measures, hopefully you could feel reasonably confident that you could keep yourself safe.
Okay, thank you. And finally, on this little section, how about air conditioning? So someone has written to say that they work in an office, a large office, which has air conditioning, but not windows. And I presume that means there'll be filters if they have air conditioning, but although they haven't said that. And we'll be asking Amy in a bit about some of the other employment things, but do you have any thoughts on that?
Yeah, again, like yourself, Fiona, I'd hope that if there was air conditioning, there would be a filter system to hopefully minimise the risk of respiratory infection. I think if you're put in that situation, I would absolutely be talking to your employer or your occupational health about your concerns and asking about a low occupancy room for yourself, a room on your own, or whether you're able to work from home if this is something that you would be able to do. So I think that requires a conversation with work about what they.
Now, I think that Rachel has frozen. So I think that's the case. So I wonder if we could, it was my last question, and I wonder if we could move on to Jonathan anyway, because that's probably a good moment, if that's okay, colleagues, to switch to Jonathan. Jonathan, I can see that you're there. Can you hear me
I'm
okay?
here. Yeah, I can hear you. Okay. So thank you very much for inviting me.
Yes, thank you very much. And Rachel, you just froze, so I thought you were at your last point, and we'll come back to you. We can come back to you anon anyway. So it's a good moment for Jonathan.
All right. Okay. Sorry about that.
No, don't worry. I thought it was me, which is also quite worrying. So Jonathan, welcome. Thanks for joining tonight. We've sent you a few questions, which I'd just perhaps like to take you through. So just a reminder to our audience that, well, Jonathan, do you want to introduce yourself?
Yeah, thanks very much. And it's great to be here. Actually, right from the beginning, Fiona and I have had a quite a number of meetings and conversations, haven't we? So about ensuring that those who live with renal disease and have kidney problems are actually taken into account. So I'm delighted to be here. So anyway, I'm Jonathan Leach. So I'm a general practitioner by background, and that's what I do here in Worcestershire. But for the last 20 months or so, I've been the medical director for Covid Vaccination for England. So it's been a huge privilege to do this job, and hopefully we've been able to make a very significant difference by the virtue of the vaccine rollout. So that's essentially, that's who I am and what I do. So do you want me to just give you a quick update on vaccine and where we are, or do you want to go through your questions here?
Oh, I think it would be great if you could just give us a sort of minute or two just on where we are at the moment, because people will know a spring dose, booster dose, etc. So over to you for
Okay,
that, please.
so this is England data. Okay, so those who may be in Scotland, Wales, Northern Ireland, I don't have it quite to hand, but I've got England data. So since we started at the beginning, we've now given 123.6 million doses of vaccine, which, you know, is just an astonishing number, whichever way you skin it, and due credit to everybody. And of those, about 70 million have been Pfizer, 41 million AstraZeneca, and about 12 million have been Moderna. So you can see the split. Certainly, there's been very, very good population uptake of vaccine, and you'll have seen all the sort of figures over many months now, and actually that has worked very, very well to our advantage. Dr. Middleton covered off a little bit about the epidemiology, so what virus we have, as she rightly said. Virtually all of what we've got at the moment is the BA2 variant, and the thing about it in comparison to the previous variants is that it does seem to be more infectious, but a fewer proportion are actually requiring hospitalization, so that's a positive thing. The concern we have, and I'll put it in the chat in a minute, is really what we may be going towards, because actually that will frame perhaps where we go in the autumn, is the BA4, BA5 variants. The European Centre for Disease Surveillance, for example, has recently put the BA4, BA5 as a variant of concern, particularly over Portugal, where it's about 37%, and we're expecting, or Portuguese colleagues are expecting those numbers to rise. And it may well be that we will see similar. The view is that actually it really just takes the Omicron just a little bit further. We're still waiting to see exactly what this is. We're still very much at the beginning of the science of this. So it may well be that it's slightly more infectious, and we may find that vaccines, again, in comparison to Delta, are not quite as good, but we don't know yet. And I think that that's something to just keep in mind. In terms of the main focus at the moment, clearly, one of the main focus is the spring booster. For England now, the number we expect would be about 5.5 million. We've given about 3.3 million, so we're over 60% of this group, and that seems to be going well. There are 3 groups, and the strategy, I go to JCVI, but I'm not a member of JCVI. The strategy of JCVI was really to bridge between the primary course and the first booster. So obviously those were immunosuppressed.
Jonathan, could you just explain what the JCVI is?
Right, I beg your pardon. So yes. The JCVI is the Joint Committee of Vaccination and Immunisation. So that's the national, across the UK, committee that makes the recommendation to the Secretary of State. So it's the main body that sort of looks at the science, actually gets presentations from around the world, looks at the evidence about what the immunizations do, and also looks at trying to predict, which is quite a difficult job, tries to look forward as well. So anyway, the spring booster is 3 main groups. So it's 75 and over, those living with immunosuppression, and then who are in residents of care homes for the elderly. So that's where we are with that. So 3.3 million is the number we've given in England now. So that's going pretty well. Looking ahead, the main thing is really, as both Dr. Middleton and I have mentioned, is about where we go for the future. I think I agree exactly with what she was saying. We're far from out of this. You know, we do expect that there will be further surges. We don't know when, and we don't know how big. We're trying to keep it down, but obviously with vaccination, things like this. We do expect that JCVI will provide guidance for the vaccination of the population, or parts of the population, this autumn. We're waiting to hear what that shows. Obviously, I'm mindful of flu. The flu campaign this year will be 65 and over, health and social care professionals and those living with comorbidities. And that would, for example, be those who have renal disease. So, you know, we're waiting to hear where JCVI will go. So the key focus, though, is on how we can protect individuals and the population. That's their absolute focus. That's where sort of there's contingency planning across the United Kingdom in terms of being able to react and respond as and when we receive the JCVI guidance. I hope that's helpful as a sort of roundup, Fiona.
Thank you, Jonathan. And there's lots of questions coming up in the chat. But however, what I'm going to do is I think many of them are going to be discussed today, and there's some about other treatments. For people who've been asking about other treatments, we're going to be discussing them later with Dr. Michelle Willicombe. In terms of the questions that you guys have put in, I think I'd just like to put a few of those to Jonathan, if I may. So some of them are pretty basic. So for people who are immunosuppressed, just to run through this, we've had dose 1, dose 2, the 3rd primary dose, then we had the 1st booster dose, and this is now the 2nd booster dose. So for many of us, this is the 5th dose. So
Yeah.
Are you able just to explain to people who can get the 5th dose, which type of kidney patient, and whether household members of immunosuppressed people are able to have an additional booster?
Okay, so I'll just concentrate on that last bit. Okay, so this is the spring booster. So the spring booster specifically is for those who are immunosuppressed. So JCVI did look at this in some detail. So those, for example, who have a renal transplant, they would be included in this group. But for example, if somebody had CKD4, CKD5, they wouldn't. Similarly,
sorry to interrupt, but there are some people on CKD5 who will be on immunosuppressants
if they're on immunosuppression. If they're on immunosuppression for that, then yes, they would. But just by itself, it wouldn't be.
Right.
So sorry, it's complicated. Yeah.
No, just to be clear. So that can be some people on dialysis who have, for example, a failed transplant, but will continue to be on immunosuppression because that's often the guidance that happens. Yeah. And there'll be some people with a whole range of different kidney diseases which are dealt with, autoimmune type diseases which are also dealt with by immunosuppressants. Yes,
that is correct. So I was talking in terms of, for example, some of my patients who might have just had sort of renal function with age which has deteriorated, and then also for the spring booster, no household contacts would not be included unless they had their own conditions.
Right. Okay. Well, that's clear as an answer. So perhaps we could just go through, how does somebody who is eligible for this 5th dose, because they are immunosuppressed, how do they get their next dose of the vaccine, particularly if they haven't yet received an invitation?
So the words I've used within the vaccination program is that we need what I describe as a permissive approach. So people do need to sort of show something. It could be, a hospital letter, say from Dr. Middleton or equivalents, which say that, this is somebody who has had a renal transplant. It could be a prescription of medication. It could be a box of medication. Essentially, it could be booked online. It could be booked through 119, and a lot of GP surgeries have been inviting people forward. So we need something. But if you like, it's not a specific referral, which was the original JCVI guidance for, if you like, the 3rd dose of the primary course. So it just needs to show on the balance of probability. It's not a very good way of putting it, but essentially that somebody said, look, and I've been vaccinating a lot here in Worcestershire, and I've seen people and they just brought a prescription along or a hospital letter, and that seems very reasonable. And then we can make a clinical judgment, work with you. If needs be, we can always get further information, but everybody's been vaccinated that I've seen.
Okay, so just a couple of points on that then, because some people are having troubles getting their 5th dose. Lots of people have managed to get it, but some people have had troubles. So is there a number or a place they should refer back to? I mean, I know lots of you are telling us here at Kidney Care UK, and we are telling people in the different countries about our medical colleagues, our vaccine colleagues about that. Is there a place people should go to?
So firstly, obviously, on to the NHS single website, it's very clear in terms of that. I'm conscious that not everybody is is not as IT savvy. So you could ring 119 and they will talk you through it and book it. And alternatively, obviously, would be, I've had quite a number working in vaccination centre where they brought something along from their GP, and that's absolutely fine as well.
Right. Okay. But if someone goes along to a pharmacist and isn't able to get something, isn't able to get their vaccination, who should they refer back to then?
So again, I think everybody would be, if they're concerned, so if they have a question, then would be to speak to their clinical team. That could be general practitioner or could be their hospital colleagues. But as I say, the information that we'll be asking is, something like a hospital letter. It just, everybody gets copied a hospital letter. You just take it with you. It's not a referral. I think that's the important thing. You just take what information you have.
Right. Okay, thank you. And just also to be clear, this says 6 months. Some of the guidance says 6 months, but can be after 3 months. So we've had a lot of questions about that, because some of the vaccinators have said, well, you're not at 6 months yet. But from the point of view of people who are potentially exposed, because you know about kidney patients, we've talked about that quite a lot. So what's the story with that? Because it can be from 3 months onwards. Is that correct?
So the guidance from JCVI, and it's a bit like we were at the beginning, later gives slightly better levels of immunity. So the JCVI guidance is to have the spring booster at around about 6 months. That is clear. However, there will be occasions where, for practical reasons, for example, if I'm not related, necessarily to this, if I was going into a care home and needing to vaccinate people there, actually practically it is useful and more helpful that everybody gets vaccinated. So we can do it from 3 months, but the guidance is later is better. So there's a judgment call to be made there. So we have had people from 3 months. We've had very few before 3 months, but if you like, the floor is no before 3 months, but later is slightly better in terms of immunity. Thank you, because we have a lot of people who are quite, who would be quite anxious and would be quite keen to get it sooner rather than later for pretty obvious reasons. So is there anything wrong with that? Is there any problem with people doing that? Not particularly, except the fact that, what the guidance is written that way is the trials show that later gives better levels of immunity when you then have that spring booster slightly later. So which is the reason why JCVI landed at the 6 months rather than 3 months. Right, okay. A couple of other questions, if I may. Are multiple doses safe for me? And is it compulsory to get a 5th dose? Okay, so the first question, all vaccination is voluntary. Okay, it's entirely somebody's choice. There is no compulsion on anybody, but clearly in terms of protecting individuals, particularly those living with immunosuppression, then we recommend it. In terms of the trials show that actually having these extra doses is fine. In fact, I'll see if I can find it. I'll put it in the chat. There's a lot of evidence now that having all these doses actually is very safe, but also sometimes having a different type of vaccine. So there was a study published, the COV study, which looked at people who had AstraZeneca first and then maybe had Pfizer and then Moderna. Mixing vaccines gave higher levels of immunity. So we've got no suggestion of that. And just in terms of safety, we're not seeing any particular safety signals either in this country or elsewhere, which are causing any particular concerns, and particularly for those people who might be more vulnerable. We're very clear that the risks of the disease outweigh the risks of the vaccine. Very clear on that. Thank you, that is clear. A couple more, if I may. I know you have to go soon, but if that's okay for a couple more questions, so that would be grand. So I think you said earlier that after this 5th dose, there will be the idea is that there will then be another dose later in the year. I think we read that somewhere. What would you anticipate? Would that be something that would be annually or would relate to these new variants? What would be our anticipation on there? I think it's too soon to say is the short answer. As I said, our expectation is that JCVI will provide guidance to ministers regarding an autumn campaign. I think that's very much there. What then flows after that really depends upon what happens to the virus, actually. Certainly, I could see potentially vaccines which particularly target particular variants of the virus, and that research is taking place. Also, I'm very conscious that, like last year, I was vaccinating flu at the same time. So if I use you as an example, Fiona, not that you were one of our patients, it would be left arm would be your flu and your right arm would be COVID. Actually, there are a lot of people who very understandably and correctly, they don't like injections, and I get that, and I don't like injections. So if we could reduce that, then that would be important. So, there's a lot of work continuing to take place in terms of how we protect population, how we protect individuals, particularly those at highest risk, and also reduce the barriers. Particularly, if I've been vaccinating, say, somebody who's got learning disabilities, it sometimes can be a real challenge in terms of being able to put that patient at their ease in order for me to be able to vaccinate. So, trying to take the barriers away, we would be very keen on.
Okay, thank you. Now, I don't know if you've heard of a study called the MELODY study, but it's one that gives, you can actually see whether you have antibodies or not yourself, and then you submit that back. I'm sure you've heard of it. So we have a query from somebody, and I think I've heard this from a number of people actually before, who's part of that study, and they have been shown to have no antibodies after 4 doses. Is it still worth them getting their 5th one?
Okay, so if we stand back from immunity from a second, broadly, what we would say is that there are 2 types of immunity. There's more than that, but if we take it at that level. So there's one where we have antibodies, and the other one's the type where we would have the cells, particularly the T cells, that would come along and deal with the infection. It's certainly true that with Omicron, never mind those with immunosuppression, that if we went and measured antibody levels, that is dropped. That level has dropped. There's no question that, and we know that vaccination wanes, particularly on the antibody levels, and that particularly is with Omicron. However, what we think, and again, this is in non-immunosuppressed population, the thing that's really stopping people from being admitted and becoming seriously unwell is the cellular immunity. And so in a non-immunosuppressed population, you're talking in terms of around about an 85% reduction in hospitalization. It would be a little less for those with immunosuppressed. So I wouldn't take away just because antibodies may be low or not measurable that people don't have immunity, because that's measured a different way. And I think that even if somebody had that, we would still be recommending the vaccinations as articulated.
Okay, thank you. And then just another one about somebody who's had quite severe reactions to their previous doses. Is it okay for them to decline the next one?
Well,
what would you advise? And of course, that people can decline if they want, but what would you advise?
I think what I've done quite a number of people is a very, very detailed history of exactly what happened. So some people have had, a reaction. Broadly, we would say that the Moderna vaccine and the Pfizer vaccines are the same. So if somebody's had a reaction to one, they could possibly have a reaction to that. Now, we've still got some AstraZeneca around, not much, but we have got some. So the thing to do is that it would need a detailed history and assessment in terms of whether or not somebody should receive that vaccine. Sometimes, for example, what I've done, and again, my colleagues and I have done, is where we've been worried about allergy. We've sometimes sort of taken a detailed history, and then I've sat with people for half an hour, actually, personally, and just checked that they're okay, and then being there if they then, had an allergic reaction, and that's perfectly fine. I'm pleased to say they didn't, and they received their vaccine safely. But it would need a detailed assessment, and without that, it would be very, very difficult to provide any guidance to anybody in particular.
No, that makes sense. That does make sense. Thank you. So in terms of people who haven't made antibodies before, you're still encouraging them to continue onwards with this. Okay, thank you. Now, I know you probably have to go, but please feel free to stay if that's okay as well, because I can see the questions popping up. And I would just remind our audience, if you could put your questions in the Q&A. If you're just having a chat, great, keep them to the chat. And we will be talking about treatments and Evershed and all those kind of things later on. We just had to chop up the questions into manageable chunks for everybody to take those through. So, Jonathan, thank you for commenting. I want to ask because I think you know that I would do that anyway. But if people have further questions about any of the things that you have said today, you're quite happy for us to funnel them through to you at NHS England, as we would do anyway, as we have done for quite some time through the pandemic. Is that okay? Because where there are problems, then I think it's important that we know that, and we share those, and we look for solutions, because people, for all the reasons you've just heard, will continue to feel anxious, to feel a bit forgotten sometimes as well. Yeah, okay, thank you. And also, in answer to whoever just asked, yes, this session is being recorded, and people will be able to watch back on any of the comments from our speakers tonight. So thank you, Jonathan. I'm going to you may wish to listen to this one. I'm going to Rachel, just really quickly before we move on to Amy, or Michelle, if you feel like answering this question, that's fine. Just a really, really quick question that kind of links directly into what we've just been talking about. And that is, I know Dr. Leach answered some of this, but just in terms of the impact of multiple vaccine doses on kidneys. So are there any long-term effects of COVID vaccines on kidney patients, specifically people with chronic kidney disease or people with transplants?
Thanks, Fiona. So no, just backing up what Jonathan said, as far as I'm aware, there's not been any studies that have shown any long-term detrimental effect from COVID vaccination in patients with kidney disease. And obviously we've been vaccinating now for 18 months with kidney transplant patients, at least having had, up to their 5th vaccine now. So no, there's not been any studies published, but I would urge anyone who had any thoughts that they had a side effect, as Jonathan said, to discuss it with their clinician. And these side effects, if they're thought to be related, can be what's called yellow carded, so that we can collect information on any unforeseen adverse events, but there's nothing to my knowledge.
Brilliant. Thank you very much. Thanks, Rachel, and thanks, Jonathan. Okay, Amy, I wonder if we could call on you to come to the screen there. So Amy Gordon is our employment specialist on the line tonight, and thank you to everyone who's been putting in your questions on work and so forth. Just to sort of set the scene of where we are now, we're talking to Amy, and then we're going to go on to Dr. Michelle Willicombe, and we'll be talking about treatments and Evershed, and if there's time, we'll talk a little bit about travelling as well. So that's our plan as we go through. So Amy, do you want to just do a little bit from the top about the kind of situation for people who are still vulnerable to COVID, but obviously want to keep on working, and what's the story with that at the moment? Thank you.
Yeah, absolutely. And thanks very much, Fiona, for the opportunity to come and speak to you all this evening, and for all of the questions that have been submitted in advance. We'll hopefully cover as much of that as possible this evening. So what I thought would be helpful just before we delve into the questions is just to give a bit of an overview as to where we are at the moment in terms of current guidance. A bit of an overview as to the relevant law that will apply to some of the topics that we're going to touch on, and also, if time allows, a little bit of a comment on so some of the issues we foresee as employment lawyers as affecting sort of businesses and workers at this stage of the pandemic. So in terms of the current guidance, what we're seeing now is specific COVID guidance being replaced with more general public health advice. The latest version of this working safely guidance, which is titled Reducing the Spread of Respiratory Infections, including COVID-19 in the Workplace, that was published on the 1st of April. And what it does is reflects the fact that a suite of restrictions that were put in place in response to COVID have been lifted, but recognises that the spread of infections such as COVID and flu in the workplace and management of those, it remains important, and also recognises that being of particular importance for those with immune systems that may be compromised and at higher risk. So the key changes are that there is no longer a requirement for those who can work from home to do so, as we've seen previously, but more general guidance that avoiding close contact is recommended, particularly if the individual is symptomatic. And those who are unable to work from home are encouraged to speak to their employer about the options that are available to them. Measures in particular that are mentioned in the guidance to reduce contact between the workforce include encouraging vaccination, ventilation, symptom awareness, and cleanliness rather than testing, which had partly been in previous guidance. Again, we don't see a reference there to face coverings to reflect the fact that they're no longer a legal requirement. We've also seen withdrawal of measures on statutory sick pay and express requirement for COVID-19 to be referred to in risk assessments. So overall, slightly less onerous measures being placed on businesses. However, alongside that guidance from the 1st of April, we have specific guidance for those with immune systems which mean that they may be at higher risk. And that was last updated on the 12th of May. And what the government says in that guidance is that employers may wish to consider it as part of their workforce management. And I know that Kidney Care have been vocalising the impact of that change on vulnerable groups and encouraging employers to take appropriate measures through their Safe at Work letter. So I would point people towards that if they wanted some further advice on opening a dialogue with their employer.
Can I just pop in at that point and just say to everybody, if you check out our website, look for Safe at Work, you'll find it there, and we'll be sharing it later in the webinar and also in the write-up. But do have a look at that Safe at Work, the letter, because it may help you in your discussions. Thanks, Amy, back to you.
Thanks, Fiona. So in terms of that specific guidance for vulnerable groups, it does recommend that anyone in that category avoid meeting anyone who has tested positive for COVID until 10 days after a positive test, and trying to avoid those who have symptoms or have a temperature or feel unwell. Clearly, implementing that guidance is going to require cooperation from employers, and is certainly something that that could form the basis of discussion. On working from home in particular, the guidance recommends exercising personal judgment if that feels right for you. And again, if you can't work from home, to speak to your employer about what arrangements they can make to reduce the risk. Separately, you might be entitled to a reasonable adjustment under the Equality Act to make that sort of arrangement available to you, and it's something that I think has been touched on quite a bit in the Q&A section, so we will go into that in a little bit more detail in a moment.
Yeah, okay, sorry, I thought that was my cue to go into the questions.
I'll just give a little bit of an overview as to the two bits of law that we're going to talk about, because I think, like you said, with some of the previous panelists, it can be useful to give a bit of background context rather than just if I make references and okay,
go for it. Yeah, please.
So this area of employment laws really falls into two categories. So we have health and safety legislation and we have equalities legislation. So the main health and safety legislation in the UK would be the Health and Safety at Work Regulations Act, and that places a duty on employers to take reasonably practical steps to assess and protect against risk. So quite a general protection there. So that involves carrying out a risk assessment and taking appropriate action in response to that. It also gives individuals some protections against detriment or possibly dismissal in cases where they do feel they need to take steps to protect themselves. You know, I don't propose to quote the legislation, but that's under section 100, which, if I were to summarize, means that if an employee has to take steps to avert themselves from danger, or, you know, for example, remaining at home, then any action by an employer to put them at a detriment for having done that, or dismissing them, would mean that would be an automatically unfair decision, and could form the basis of a claim at the employment tribunal where higher compensation can be awarded. And the other key piece of legislation is the Equality Act 2010, which may be familiar to some of you. So what that legislation regulates is that it's unlawful for an employer to discriminate against an employee on the grounds of a protected characteristic. And the key one for our purposes here would be disability. So an employer can't treat someone less favourably than they would a non-disabled person. That's unlawful and cannot be justified. Separately, an employer can't apply a policy that applies to everyone but treats disabled people, it creates a particular disadvantage for them. However, that type of discrimination can potentially be justifiable if the employer can demonstrate a good reason for the policy. And then the other key bit, as I mentioned earlier, would be reasonable adjustments, which places a positive duty on employers to help employees to do their job if their condition puts them at a substantial disadvantage. And I think perhaps that would be a good segue into the questions, and we can get into that in a bit more detail, Fiona.
Okay, that's great. It always goes so quickly, these sessions. So I'll kind of sum up some of them. And I think some of the questions we've been asked, you have summarised about in terms of the Equality Act, about people being, because not everybody is necessarily classified as disabled if they have a transplant, for example. So there's kind of, I guess there's a kind of a middle ground for some of this stuff, and I wonder where that goes. But the specific question here is, are people with transplants or on dialysis covered by the Equality Act? And I think, could you just respond to that? Yeah.
So whether a person is disabled under the Equality Act is a legal question, and what the Act says is it poses a couple of questions to see if a person would meet the criteria. So first of all, they need to have what's either a physical or mental impairment. That impairment must also have a substantial impact on their ability to carry out day-to-day activities. And lastly, it must also be long-term. So it lasts 12 months or is likely to last 12 months. And what's important as well to note is that the impairment, or the impact of the impairment, is judged before that person receives medication. So it's, if you didn't have access to your medicine, would your condition have a substantial impact on your ability to carry out day-to-day activities? In reality, I would expect most people who receive transplants to meet that criteria. If you are unsure, then it's something that, so if you're involved with occupational health, then they may make a recommendation on. It's not always binding because, as I say, it's a legal question rather than a medical question. But it's certainly something that that I would expect anyone that has received a transplant would likely be covered.
Okay, so I'm a self-employed therapist. What are my duties towards my clients? How can I keep myself safe? That's one of the questions. Mm-hmm.
Yeah, so there, in terms of the self-employed, they, under the Health and Safety Act, they don't have quite the same duties towards I suppose clients or patients as an employer does towards their workplace. But what they do need to do is make sure that their work isn't putting themselves or other people at risk. So as a minimum, the person that's asked this question, I would say, should be complying with although it's not binding in the same way, with the government guidance in terms of ventilation, cleanliness, all of that type of thing that would, I would say, be seen as the minimum to ensure a safe environment at this stage.
Right, which is both safe for them and the person they're treating.
Yeah, and same, although there isn't a specific requirement to do a risk assessment, it's something that might be helpful to sit down and give some thought as to what could be potential areas of risk, and to look at what could be done to minimize those, also taking account of your own comfort levels, and communicating that to your clients to make sure that they know what your measures are and that they can comply with them as well.
Important point. So if I find out that a resident co-worker has COVID, what's the best way to approach this so not to be at risk?
Yeah. So I suppose, setting aside any legal considerations, the best way to approach that type of scenario will in large part be motivated by personal choice and what feels like the right decision for you and your health. Now that self-isolation is no longer mandatory, employers are facing that sort of competing rights in the workplace when managing that type of situation. On the one hand, the employee with COVID can't be compelled to refrain from the workplace in the same way that they could previously. Yeah. But on the other, we need to strike a balance that's fair to take account of staff that may be experiencing increased levels of anxiety at that prospect. And as a minimum, employers should be putting in place any reasonable control measures that they can. For this individual, what I'd recommend is speaking to your employer to explain how you feel, and ask for help in making sure that you feel safe at work. That might include temporarily working from a different location, or doing adjusted duties. And I would propose, if it's possible, speak with them to try and collaboratively reach an agreement, particularly if you feel that perhaps absenting yourself from work might be the solution. Lots of employers have policies on unauthorized absence, which they treat quite seriously as a potential conduct issue. So making sure that you're really clear with your employer at the beginning about what your concerns are, why you think that type of action might be appropriate, and trying to get some pre-approval for time away, if that's what's right, is really important.
Right, okay, because that's come up through several different questions in various ways. I have another question though, which is, have there been any successful cases tried on the basis of some of the risk for COVID and their right to work from home, either as an individual or for their partner? And I don't know where the law stands with the partner either. Yeah,
so in terms of, I'll touch on the last point and then come back to some cases. So you're right, there is a concept under the Equality Act that prevents discrimination by association. So you cannot be treated less favourably because of an association with a person with a protected characteristic, in this case disabled. In reality, that's a more complex type of claim to bring, and is, or certainly up until recently was less common. The law has now started to look at whether that type of claim is possible for an example of indirect discrimination. So if the employer says everyone has to come back to work, but that places those with family members at home that are disabled at a particular disadvantage, whether they should be able to pursue a type of claim. And it may be of interest to people to know that there was a case recently. I'm going to find the name of it so that people, if they want to take a note, pretty sure it was Fellows Against.
We can always share it afterwards for people.
Yeah.
Because
it was Follows Against Nationwide, so hopefully the employer name will stick in people's
Nationwide. Okay. Anyway. Was that a successful case?
It was. So in that case, the employee was the primary carer for her disabled mother, and the tribunal did accept that the requirement of nationwide for employees to return to work put that employee at a disadvantage, or put employees who are living at home with disabled people at a disadvantage. It's only a tribunal decision, so it's not going to be binding on courts at higher level, but it's an indication of where we may see those case law in that area develop, and so an important one to be mindful of.
Right. Okay. Thank you. Now, I think you can pick this one up, Amy. I've just seen a question, and then we'll move on to Dr. Willicombe, if we may, just because time it's just flying away here. But the request was just about, in terms of offices, air conditioning. So employers, the things that they would be advised to do would be put in ventilation, air conditioning, filters, etc. Is there anything that we can say about that, about what employers would be advised to do to keep people, everybody safe, actually, not just people who are immunosuppressed?
Yeah, absolutely. So, there is a sort of standalone requirement under health and safety legislation for employers to provide a workplace that has, a supply of fresh air, or to take steps, as you mentioned, through other means to, if you can't provide fresh air, to provide, clean and healthy air. I suppose on that point, effectiveness of ventilation is a sort of question of engineering as well. So I think that there's the opportunity there for, in certain workplaces, perhaps to be trying to access sort of specialist advice. That there are people that do that as a job, in terms of what's the best type of filters and that kind of thing. So that certainly could be appropriate in workplaces where there's concern about meeting that legal requirement, where it might be appropriate to get that type of advice.
So people have the right to ask about any of that to their employer or the occupational risk assessment person?
I would say if it's a concern, discuss it with occupational health, discuss it with your employer, and see talk together to find a solution.
Right, thank you. And to finalise my last question here, is there a right to work from home still if you are at risk of COVID?
The short answer is no. There isn't a right per se to work from home, or a recommendation that we should be working from home in the same way that we saw under the previous government guidance. However, it is feasible that someone who was disadvantaged by a requirement to work in an office, or just simply to not work from home, could be covered under the legal duty to make reasonable adjustments. That's always going to be a question of circumstances and facts. So what might be a reasonable step for one employer to take might not be reasonable for another. And as with a lot of employment law, it is very fact specific. So again, I would recommend that if that's something that you're concerned about, to engage with occupational health, speak to your employer, and see what the lay of the land is in terms of a solution there. Also important to mention that whilst there may be employers out there who haven't embraced home working, that have not moved with the times in terms of where we were in 2019 to 2022. With some optimism, I can say that there are businesses out there who absolutely have embraced changes, and whilst it's not a circumstance of anyone's own making, the looking out there and seeing what might work for you in terms of your personal and career aspirations with another employer is something that could be a really fulfilling resolution to some of these cases, rather than engaging in a sort of long sort of dispute or anything like that. So
Thank you so much, Amy. I'm going to have to move us on, though. Thank you for all your advice and guidance. I'm sure people will have found that helpful. If I could now move, thank you so much. If I could now move on to Dr. Willicombe, we have a range of questions now for people, and I know there's been a lot of chat about this as well. So there you are, you're still there. That's great. And this section of the webinar, we'll be talking about what we know now. We'll be talking about some of the treatments, and I know there's a huge amount of interest in something called Evershed, which some people are saying, what on earth is that? And other people know all about it. So I think it's probably time for us to get into that, Dr. Michelle, if that's okay with you. So probably we should kick this one off just with a kind of a, where are we at the moment, basically? What's the, how effective are the current well, what do we know, first of all, about how effective the vaccines are? I know there's some reports on that. And secondly, just if you could just start to touch on some of the new treatments, what they are as well, and how well they work. So both of those things, if we could get into that, would be great. Thank you, Michelle.
Yeah, that's fine. Can you hear me?
We can. Luckily.
Okay, good.
That's good to know.
Okay, so in terms of the vaccines, the lab data comes through before sort of the real world data. The real world data is the thing that's we're collectively more interested in. But in terms of the lab data, what we know for patients with chronic kidney disease and for those on dialysis who are not immunosuppressed, is that following every vaccine dose, there's a boosting of antibody levels, which is very nice. The vaccine response to the COVID vaccines is actually quite good, which is very good news and encouraging. For patients who are on immunosuppression, for an array of reasons, or for those with transplants, the data isn't as comforting in terms of antibody levels. So, for example, what we know about the vaccine in the transplant cohort is after the first two vaccines, approximately half of the transplant patients got some responses. That's why they needed the third primary to allow them to catch up. Then after the third and fourth dose, approximately 1 in 2 patients each time who didn't have any detectable antibodies before number 3 and before number 4 have detectable antibodies. So it is very important that patients, even if they have no antibodies, get their subsequent vaccine doses. I'm not aware so far of any data on the 5th doses. But there is certainly a good response in the non-immunosuppressed kidney population, but for immunosuppressed patients and transplant patients, they're less effective, which we sort of predicted from the fact that they're on immunosuppression to dampen down their immune responses for their underlying condition. What we know so far about the impact it has, or the real world data on how the vaccine is impacting on protecting against hospitalizations and death, certainly it gets a little bit a little bit confusing to interpret, because there's a combination of factors now. Certainly, as Rachel already sort of suggested, the Omicron infection itself seems to be less severe, although it's much more sort of contagious and transmissible. There seems to be less severe in general, in the general population as well as the kidney population. But we also have vaccines and effective treatments, which are all contributing to the good endpoint, in that we are seeing less hospitalizations and certainly a huge reduction in deaths across the board in all the different kidney populations. There is still a concern, though. We are still apprehensive and cautious optimism, as Rachel said, in that, there are still some, certainly the immunosuppressed population who we're concerned about, and this is at a local level, but we're hoping that there'll be some data that will be coming out from the registry, so NHS Blood and Transplants and another collaboration of GP records called the Open Safely collaboration, that will be able to provide more information on larger numbers to be able to back up what people are seeing on the ground. But hopefully that will be coming out soon. But I said, I think a combination between multiple vaccine doses, the weaker infection, early treatments are all contributing to better outcomes in our patients. And it's just the overly immunosuppressed patients who I said that I'm worried about sort of locally. So in terms of treatment options, if I just move on to that quickly, because I know time is running out. So the treatments haven't, the treatment priorities in the community haven't changed since February time. So the first line treatment is Paxlovid or Sotrovimab. Second line treatment is remdesivir, and third line treatment, remdesivir being an antiviral drug, and the third line treatment is molnupiravir, which is another antiviral drug. Certainly in terms of I think Paxlovid is difficult for certainly the transplant population with drug interactions and some other drug interactions with people with sort of kidney disease. So most of our patients are still receiving Sotrovimab. And I know there is a concern in terms of the efficacy of Sotrovimab against the newer variant called BA2, which the lab data is suggesting may not be as effective as the prior variant of the BA1. But at the moment, there's been no change in direction from the government in changing the priorities of those treatments. And I suspect that, you know, and I haven't heard of any rationale for that, but outside of the kidney world, all those treatments have been shown to be beneficial in preventing deterioration of health following infection and hospitalization.
So just to be clear, Sotrovimab is the one that's given as an infusion, so you have to go into hospital for. Molnupiravir is a tablet that you take at home and is sent round to your house. Is that right? Yeah,
that's absolutely correct. But less and less people are getting offered molnupiravir, and certainly for the kidney population, Sotrovimab seems to still be, certainly the immunosuppressed kidney population seems to be the first choice of agent.
Right, and then to summarise for everybody, so if you do test negative on a lateral flow test, you either ring up or you go online and you report your result, and then you should be contacted about which treatment you're going to be given depending on how bad your symptoms are. That's how it's meant to go, isn't it?
Yeah, so if they test positive, don't need a PCR. This can just be done on lateral flow, which was a big change. And you'll need to be within 5 days of that positive lateral flow test, and they will ask whether or not you've got symptoms at all. And you know, not all the patients have symptoms, and then you won't receive them unless you have even mild symptoms.
Right, okay, that's fine. And if people are worried or they don't hear back, they can let their kidney unit know, or call their GP as well, if they're not hearing back fast enough and they're worried about that.
Yeah, absolutely. And I know at the start of the rollout there was some difficulty with everybody, you know, getting rapid access. But I've heard less stories recently that there's a problem with access, but certainly chase.
Right, okay, that's fine. And do we know about how effective those treatments are? Well, especially the Evershed. So my brain is my next question, but one, the Sotrovimab, is that is reasonably effective on people for some of the variants?
Yeah, so it was very effective with the BA1 variant, which that wave has now gone because it's converted to the BA2 variant. And so I haven't seen any clinical or real world data I know some of our patients are still receiving it locally and are doing okay, but there is concern that it's not as effective against the BA2 variant than it has been against the BA1 variant. And it has been withdrawn in some of the, or it's not used in some of the states in America because of that. But the UK government and, you know, and I don't know why, I can't answer for them, there hasn't been a change in policy for changing that at the moment.
Okay, thank you. And so to summarise, at the moment, options which people are encouraged to do are take the vaccinations as and when offered, and obviously if you do get COVID, to report in and take the treatments that you are offered. And that then leads us to the question about which there are probably 40 questions in the Q&A at the moment. And I know you can't answer those questions, we can't answer those questions, but let's just run through some of them for clarity of where we are at the moment. So first of all, a lot of people are interested in preventative treatments, and there is one treatment around at the moment which is called Evusheld, which is a long-acting antibody. Michelle, could you just explain what it is, and if you, and I think you've already said there's no update, but if you could just summarise for people what that particular treatment is and whether it could be a game changer. Thank you.
Yeah, so Evusheld is another one of the monoclonal antibody agents that are used to prevent or to treat infections. So like sotrovimab, it's just a different version of that. The beauty with Evusheld is that is also reportedly long acting, because all these other monoclonals like Ronapreve that people may have heard of, as well as sotrovimab, they're relatively short acting, whereas Evusheld can be used as a prophylaxis, and it provides at least sort of 6 months protection. Now, Evusheld is being used in a lot of countries around the world, and we have had MHRA approval for the emergency use of it in the UK, and all the COVID-related drugs, most of them are emergency approval. But I am not aware that the government has asked for a supply of Evusheld in the UK currently, although I'm not in any inner circle, so things may change. I think the difficulty that we see with the monoclonal antibodies, so these are neutralizing antibodies which will prevent you becoming infected if exposed to the infection, is that their benefits or their efficacy changes with the different variants. And already with Evusheld, certainly if we had it, if I could prescribe it in the clinic, in my transplant clinic, I would do it for the heavily immunosuppressed patients, for while at the moment with the BA2 variant being sort of most dominant in the UK. Although there's a small amount of data, and it's not clinical data, this is just lab data that suggests that it may not be as beneficial against the next variant, the BA4 and BA5. And so this is a problem when I assume this is what the government are taking into consideration, is that if there's different variants and needing to change these antibodies each time, then actually trying to keep up is technically or logistically very, very challenging. And that's really all I can say sort of specifically on it. I think it would have been nice if we could have offered it out even to a select population, but there's not been an opportunity in the UK here.
Right, okay. A couple of other questions then on that. People are asking, I think I know the answer, but I'll ask you in case you have any more on that. Can people buy it in another country or even in this country?
I am not aware that whether or not you can buy it privately. I wouldn't have thought so in this country. Outside the country, I'm really not sure. I said it would. it's not something that I would like to give any sort of advice on, because as I said, I just don't know the policies and the processes for trying to obtain things privately here or abroad.
Yeah, I thought you would say that, and that would reflect what we would probably say at the charity as well. But because people have asked, you know, we need to discuss all of this, and I know people will be very disappointed in all of this. And I should say that, you know, we are Kidney Care UK, and I know you are as well. We are all pursuing this actively. You know, outside of this, we are writing to government. We're writing to the, you know, the different health teams. You know, you can write to your MP about any of this. So you know, so government is being extremely cautious and perhaps quite slow in this, in getting its approval out there, and that is a concern. The product was approved more than a month ago, well over a month ago now, possibly even 2 months, coming up to 2 months ago. And we'll keep trying, but obviously we can only tell you today what we know rather than anything new. And of course, keep following us, because we'll always tell you if something new is, we'll be the first to tell you. But perhaps on a slightly more positive note, are there any other treatments, you know, like niclosamide and others, which might offer some help to people who are going to be anxious here?
Yeah, there's definitely ongoing. I mean, I still think, you know, a lot of patients will respond to the vaccine, but but there are different treatments that are being tested, and part of the Protect fee, which is niclosamide, which is a nasal spray to try and prevent infection. There's also actually there's talk about using nasal vaccines being brought in that may be highly effective. So actually changing the way that the vaccine is delivered may be of benefit to the immunosuppressed population. So I definitely I'm keep my eye out for evidence of that. And yes, and it's not, in terms of prophylaxis, it's not the end. There is there are people trying to provide evidence for, you know, our cohort of patients.
I think it's fair to say there's been a very strong advocacy throughout COVID for all of that, and I know that lots of people in the audience have heard that message. So the more you keep telling us, and so forth. And yeah, we do send joint requests, we do individual requests, we do joint requests, we work with other charities, we do lots of different things on all of this. We don't share every single moment that we've met with a different official and written a different letter, because because it would just get everybody excited. But I mean, rest assured, we are talking about this every single week to different people, and we're meeting the vaccines minister soon. We'll be mentioning it again to her, and all of those things. So we are coming very close to the end of the webinar. There is one other question someone was asking about traveling, which was which just, I think the same answer is, for a different question. If someone is going to travel, go to a different country, I don't believe there's any way you can take any of those existing treatments that we talked about, the antivirals, with you on holiday. And I think that's the case, isn't it, Michelle? Because lots of people have asked us that. And there's no way people can do that, because you would only get those treatments if you have COVID. So that's completely different to Evershed or another product such as niclosamide, which would be given to protect you from getting COVID. And those are different products, those are different things there.
Yeah.
So anything else you'd like to say? Because I just need to spend 30 seconds thanking everybody and wrapping up for the moment.
No, that's I think no, I think most things have been covered.
Yes, thank you.
I think, no, there's one thing I'd like to say about the antibody testing. It's a very common question at the moment. It seems a bit of a postcode lottery in those who can obtain tests clinically and those who can't. We as a community feel very strongly that the immunosuppressed population and population with kidney disease are able to access testing in order to try and help stratify their risk. But that's all I'll say. So we're trying.
Thank you so much, and thank you. I wonder if we could, colleagues, if we could just put on the last couple of slides, please, so we can just thank everybody and give you an opportunity to let us know what you think of the webinar, what more we should be doing, etc. So I don't know if, I think that was possibly Phoebe. So if we could just click along, please, and on again, please. A couple more to the, And the next one, please. Right, so just here we are. So if you do need advice, that's where we are. If you need financial or emotional, practical support, this will all be in the write-up for this as well. So don't worry about scrabbling to write it down now, and you'll have access to this subsequently if you want to go back and listen again to some of these sessions. But that's what we do as a charity. So please feel free to benefit from all of that if you or your family members are affected by kidney disease. And if we could go on to the next session, the next slide, please, which is some other resources there, which again we'll be sharing. Anything on COVID. There's our Safe at Work letter I spoke about earlier, and some good tips there. And if we could go on to the, I think it's almost the final slide, we have a survey which we'll be sharing with you afterwards. So do take a moment, just tell us what you think, because this is how we shape what we do. And I know it's been incredibly busy tonight, but I do want to thank all of our speakers. So that's Dr. Rachel Middleton, Dr. Michelle Willicombe, Dr. Jonathan Leach, Amy Gordon, because you've all been a font of fantastic information. There is so much out there. And thanks to all of you for continuing to listen all the way through, sharing with us your questions, your thoughts, and we'll keep working with you and for you as much as we possibly can, because that's what we're here for. And I wonder if there's a final slide. And thank you for joining us. I think that's probably all it is. And if before we close down, if any of our speakers want to come on and just give us a grin, that would be great. But thank you all for your time, and thank you everybody for joining in. I don't think there's anything I missed. I'm just going to look and see if I've got anything else. No, I don't think so. And thanks to the Kidney Care UK team for all of that as well. Phoebe, Kelly, Sam, Sharon, all of you. That's been wonderful, and we'll speak to you all soon. And thanks very much, and good night to everybody. And please keep safe, keep cautiously optimistic, as Rachel Middleton said, and Michelle Willicombe. Thank you, everybody, and good night. Take care. Bye bye for now.